that these guidelines were launched. They are on your tables. You can take a look at them. But also allow me to recognize the members of that committee that stood and made sure these guidelines were launched on Wednesday. So any member present of the committee, I kindly ask you to stand up for recognition, because it's your hard work that resulted into this guideline. So we appreciate you for the great work that you have done. So I'm inviting all of us to engage deeply. I urge all of us to engage deeply, actively listen and participate, and boldly, I ask that we boldly contribute to this conversation, because it's important as we advance the safe motherhood agenda as a country. I believe that together we'll be able to shape our future where no woman dies, no young girl dies from preventable causes. So we believe that out of this conversation, every girl will have access to dignified, timely, and safe care. So to set the ball rolling, I'm going to ask the panel, as I introduce them, they'll be coming they'll be coming up. So like Dr. JP previously mentioned, that this session is framed within strengthening post-abortion care and advancing reproductive justice for safe motherhood. We are going to have a keynote address that will be led by Dr. Kitui Musoba. He's the director, IFAS Africa Health Alliance. Dr. Kitui will frame our conversation, and the panel conversation will then grow from what he will be discussing. So allow me to introduce Dr. Kitui as he comes here. He spearheads efforts across the region to advance reproductive justice and expand access to contraception and safe abortion services. A medical doctor with an MPH from the University of Nottingham, he brings 20 years of progressive leadership in public health and development across Africa, Asia, and in global roles. His extensive experience includes leading large-scale programs focused on maternal and child health. Dr. Kitui's background combines clinical expertise with senior roles at organizations like Oxfam, IMA, World Health, and MSF, ensuring a holistic, systems-based approach to health. He's a strong advocate for health equity, accountability, and rights-based interventions, and his research has focused on improving health facility delivery uptake in Kenya and the region at large. Dr. Kitui Musoba, you're very welcome. Joining us on the panel is a moment, please, is Miss Judith Isuka, a senior midwife at Mujuku Health Center 4 in Toro District. Judith will help us frame the conversation as a frontline service deliverer. She'll help us further define, tell us about the provision and providers' realities when it comes to PAC services. I'm privileged to have worked with Judith Isuka before. She's a registered midwife and a post-abortion care mentor and provider serving in Mukuju Health Center 4 in Toro. She has 20 years of experience in health service delivery with a strong focus on maternal and child health, post-abortion care, and family planning services. Judith is deeply committed to promoting safe motherhood and improving access to quality reproductive health services at the community level. Her passion for mentoring fellow health workers and advocating for women's health continues to inspire her work in advancing reproductive justice in Uganda. Ladies and gentlemen, please meet Judith. You're welcome. Next, I have the honor of introducing Dr. JP Bagala. We all know who he is, but allow me to speak about who further. I don't know if you know all his titles and the good work that he's doing for us. But Dr. JP Bagala is an associate consultant of obstetrics and gynecology with the Ministry of Health and a scientist and lead NASMIC Institute. He is currently the acting assistant commissioner of reproductive health and infant health at the Ministry of Health. He remains the national coordinator for the local maternity and neonatal systems at Uganda Ministry of Health. He serves on the advisory board of Africa at the International Urogynecological Association. Dr. Bagala leads initiatives to strengthen maternal and neonatal care and collaborates with health workers, policymakers, and development partners to advance evidence-based interventions across Uganda. Dr. Bagala will be able to frame a conversation around national policy and health systems leadership, and he will be contributing around institutionalizing PAC across Uganda's health system. So with so much honor, join me in welcoming Dr. Bagala to this conversation. It's an honor. Allow me next to introduce Dr. Lois Nyanjao. She was very clear that she loves her botanical name. So Dr. Nyanjua will be giving us a regional perspective about policy and health system strategies from Kenya. But that awesome lady is a distinguished local global health leader with over a decade of experience shaping large-scale health programs across Eastern Africa. Renowned for her strategic vision and transformative leadership, Dr. Lois has consistently driven health policy reforms, regional partnerships, and resource mobilization efforts that align with both regional and international priorities. Currently, serving as head of maternal health at Kenya's Ministry of Health, she leads the national maternal health agenda, advancing high-impact interventions, strengthening quality of care, and improving system coordination across counties. Her previous leadership roles include head of early childhood development, where she guided Kenya's transition to the nurturing care framework, and head of partnerships and coordination in the National Cancer Institute of Kenya, where she mobilized funding, convened the first National Cancer Summit, and oversaw the rollout of Kenya's digital cancer registry system. She has also held strategic positions in primary health care, cardiovascular disease prevention, and universal health coverage, as well as represented Kenya in global forums as UN liaison officer, building bridges between national systems and national health networks. You're welcome, Dr. Lois Nyanjua. I believe her bio speaks to the overall agenda I've been speaking about since we came on Wednesday. Yesterday was a self-care conversation, and the work she has done within the NCD, I think that speaks to further enhancing the safe motherhood agenda. But last but not least, allow me introduce Dr. Polyfield. I have no power to pronounce his second name, and I hope that once he comes up to speak, he will be able to say it. Dr. Polyfield is a prominent academic and researcher. She is based in Rwanda with a focus on public health and clinical medicine. He's an adjunct assistant professor of obstetrics and gynecology at the University of Utah and a lecturer at the University of Rwanda. Dr. Polyfield's research encompasses a range of critical topics, including the prevalence and management of post-menopausal symptoms, as well as maternal mortality causes in Rwanda. His work has been published in reputable journals such as Climate, and Obstetrics and Gynecology, highlighting his commitment to advancing medical knowledge and improving healthcare outcomes in resource-limited settings. In addition to his academic pursuits, he has been involved in practical interventions aimed at enhancing evidence-based practices in the management of acute infections. His studies, particularly those conducted at Gitwe Hospital, reflect a dedication to addressing pressing health issues through rigorous research and implementation of effective healthcare strategies. I had to read that out because they are joining us from Rwanda and Kenya in the region, and they deserve for us to get to know who they are. So Dr. Polyfield will be speaking about will be providing legal clarity and innovation in PAC delivery. And we believe that we'll be able to learn from Rwanda's experience. That took a while, but I believe it was worth us understanding who's speaking to us and the value they bring in this safe motherhood conversation. So We have, like I'll say it again, that we are framing our conversation around reproductive health, reproductive justice in relation to PAC, post-abortion care services. So let us begin with a keynote address from Dr. Kitui Musoba, the Regional Director at IPAS, whose leadership continues to anchor national and regional discourse on reproductive health and justice. We are believing that his conversation will frame PAC and reproductive justice and then lead us into the panel discussion. You're very welcome, Dr. Musoba.
I want to stand on the protocols that have been established throughout these past 2 days. And so, ladies and gentlemen, good morning. It's a great pleasure to speak to you today on the topic of strengthening post-abortion care and advancing reproductive justice for safe motherhood. And I have a speech here that I don't want to read word to word so that we can have a conversation. And so I'll just talk through my key messages even as I frame this topic. But before I go into the substance of my keynote address today, I want to start by congratulating the government of Uganda, and especially under the leadership of the Ministry of Health, for the great work that they are doing to save the lives of mothers in Uganda. I think I've been personally very impressed, especially with the statistics, with the progress that we've made as a country over the past 10 years. But still, one too many women still die from preventable causes. And I think, as a society, to be honest, I think we should collectively be ashamed every time a woman dies from giving birth or from a pregnancy-related matter, because it's completely preventable. Especially in 2025, we have all the technologies we require to save women's lives. And I know the Minister of Health has really been on the forefront to lead us all in making sure that we save the lives of women and girls. So the leadership of the Minister of Health, institutionalizing, including the post-abortion care guidelines and life-saving services, because we know that despite the proven benefits of services like post-abortion care, these services remain completely inaccessible. And we can talk about some of the drivers of why women who require these life-saving services are not able to get them, including stigma around abortion in itself, the divergent views on sexual and reproductive health and sexual and reproductive health rights. And PAC services is I know Dr. Richard says that we finished all the low-hanging fruits, but I feel like post-abortion care services is one of those low-hanging fruits in advancing safe motherhood in our country. We also know that even where an abortion is medically indicated, as per the laws of the land, saving lives, for example, even a good quality abortion cannot be provided to some of these women as well. And so even the unsafe abortion services actually happen in our own health facilities, partly because of lack of skills or lack of equipment or lack of clear guidelines. And I think for me, that's why the advancing of these post-abortion care guidelines really plays an important role. I would like to move to my second slide. I think why yeah. So why does post-abortion care matter? I think we saw early this week, around the statistics of the women who are dying in our health facilities, and complications from unsafe abortion play a very, very significant role to that as well. For example, when you look at thank you. Yeah, so when you look at the complications from abortion, we see the figures going down, but we're still at 4%. There was another figure there also about pregnancy-related sepsis. These are women who come in from infections, and they have high fever, and they require antibiotics. And I think I want to speculate, and I can be corrected, that some of those infections and sepsis are usually arising from complications of unsafe abortions that have happened elsewhere, and then women show up in health facilities because of some of those complications. And I think under the ministry's stewardship and the technical leadership in this space, we are seeing very significant progress. For example, approval and inclusion of drugs like Combipac as a life-saving drug within Uganda's essential medicine lists, the establishment and leadership of the National PAC Steering Committee that we've just acknowledged because they've provided leadership to the creation of the guidelines that exist. The development of the National PAC Training Manual as well will really help to build the skills of healthcare workers at facility level to provide these life-saving services as well. But also championing of self-care approaches, including the use of digital technology that we've seen this week, giving women the autonomy to manage their reproductive health as well, and the provision of infrastructure and enabling environment that allows partners to complement government efforts through commodity supply and provider training and community level interventions. Also the establishment and functionalization of local maternal and perinatal death surveillance structures, I think for me is very commendable, because then for every woman who dies from either complication related to pregnancy can be audited, and those issues that really underlie why the woman dies can be addressed. Where am I supposed to? Oh yeah, there we go. So I think the other question I wanted to ask is, why is post-abortion care services necessary? And I think for me it's really important for us to look at the upstream causes and determinants of unsafe abortions in Uganda so that we can be able to have a very open conversation around what we need to do to save women from dying. And I use the analogy of a stream because I think for me this is probably, it frames the issue better for me. So when you talk about post-abortion care, we're really talking about preventing these last deaths here downstream from a cause that we can actually prevent. It should not be lost to us that by the time a healthcare worker gets a girl or a woman who requires post-abortion care in a health facility, that we as a society have failed her so many times upstream already by the time she reaches there. And I also symbolically use the symbols of male and female, because if you go upstream on the bridge, it means that upstream there are women who are falling through into the river, but we're not picking them up early until a post-abortion care service is necessary. And so, for example, when you look at every time a girl or a woman dies from complications of a safe abortion, is the immediate cause is that we could not be able to provide post-abortion care. And we could not a healthcare worker could be there, but maybe they are not even allowed to provide post-abortion care in the first place. And this could be lack of skills, lack of equipment. We have the MVA kits, for example, that could easily do that as well. Or if you're a midwife or a nurse, maybe our guidelines say that only doctors can do manual vacuum aspirations. And therefore, a woman dies in our health facility because we've just failed her at the facility level. And most of the time is because of things that we can actually do. And I think I was really encouraged by the kind of conversations we've had this week, and especially the efforts led by the Commissioner, Dr. Mugahi, in terms of making sure that we have equipment, the skills, the healthcare workers, and health facilities. And we're doing even skills transfer and task shifting or task sharing with other cadres of healthcare workers who can provide our services. But if you follow upstream a bit, you realize that why do we have unsafe abortions in the first place? And I think we were reminded, I think as has been mentioned by Dr. Lillian, is our girls are having sex. And it's 2025, and we can try to wish that away, but our girls will continue having sex. And they're not having sex by themselves. They're having sex with the men or boys, for that matter. But the consequences of, and I'll come to that later, the consequences of unwanted or unintended pregnancies 100% lie on the girl and the woman. And so they are seeking unsafe abortions because we as a system fail to provide for them options out of these situations that they find themselves in. So if you go upstream, you see again unintended pregnancies, and these unintended pregnancies happen because of many reasons. We can easily say, oh, let's make sure that family planning is readily available. But for you to really understand, then you have to go upstream again to figure out, why are people having sex? Or why do we have sex? And I'm sure you can list a whole list of reasons why we have sex in the first place that then makes post-abortion care downstream necessary. And some of that sex is consensual, it's wanted, it's out of pleasure, It's for many other reasons, but sometimes it's out of violent acts, rape, incest, abuse at household level, the lack of power by women, even among married couples, to negotiate for sex, for example. These are the drivers of some of the unintended pregnancies that arise from the sex that we have in society. So a lot of the sex that is happening in society is not necessarily at the control of the woman, who then bears the consequences downstream. And then we leave always the men off the hook, who are actually 100% of the cause of the unintended pregnancies in the first place, whether violently or through consensual sex as well. So I think for us, as we engage with the issue of post-abortion care, let it not be lost to us that there is upstream causes that are causing these women to fall off the bridge into the water, that we as a system, multisectorally, have to go upstream and figure that out and fix that as well. It's not enough. PAC saves lives, but I think I want to make that it's not enough to just save lives downstream when we're not dealing with upstream causes as well. So, and I think for me, this is where the concept of reproductive injustice comes in, because mortality from complications of unsafe abortions are not random. They are not random. So when you look at the people who are dying from unsafe abortions, they are first of all 100% women. Where are the men who plant these seeds? I've never seen a man who's died from complications of unsafe abortion or intended abortion as well. Because where are we? So I think the first challenge we have to do is we men have to take 100% responsibility for sowing those seeds that make post-abortion care necessary. And there are many, many ways that we as men can take responsibility, including making sure that we are not violent, consensual sex, for example, but also standing up for the rights of women when they want those services, because we planted the seed and then disappeared from the picture. We also see the rural and urban divide on this as well. Death from complications of unsafe abortions are also very economic, in the sense of wealth dictates the access to care as well. If you are a woman of means, if you don't want an intended pregnancy, across the world you can get a very good safe abortion anywhere. Even if it means flying to Kenya or the US, you can always do that. So you see then the inequality of complications of unsafe abortion as well. And then we see regional disparities, but also we talked about the teenage crisis, which I don't really want to belabor. But we are really failing our young girls and women. There's a research that was done in Kenya recently by the APHRC, that shows that in Kenya, in 2024, there was about 762,000 abortions. Out of that, 80% were from married couples. So there's also a lot of myths around it as well, because women in marriages are getting pregnant and they don't want those pregnancies, and they're ending up having abortions and they're not dying. Why? It's because they have means, they have economic ability, and therefore the economic element for that, I think for me, is what really describes the injustice around this as well. So when you talk about reproductive justice, for me it's a broader framework that includes reproductive rights, but also addresses the social, economic, and political conditions that impact reproductive health and choices. When we talk about reproductive justice, we're actually saying the right of every woman to have a child, to not have a child, and to be able to parent a child in a very safe and healthy environment. It's a principle that emphasizes that reproductive freedom encompasses all these choices. And I think as society, especially men, we can play a bigger role to advance that as well. So I really want to really commend the Ministry of Health for some of the stewardship that they provided. Especially, I think I mentioned the issue of CombiPack, the PAC guidelines, the training manuals, the self-care approaches that really can go a long way to reduce some of these deaths. And in terms of health system readiness for post-abortion care service delivery, ensuring autonomy, equity, and safety, I think for me is really important. And to really emphasize that, Dr. Gahi, we have not finished with the low-hanging fruits. And I think for me, making sure that all facilities are fully equipped with facilities like the MVA kits, misoprostol, CombiPack, is a necessary first step. Training healthcare workers, VCATing them so that they have their values clarified, so that they can provide services with less judgment on clients who are coming to them, I think is equally very important. But also having strong referral systems, I think is equally important. But post-abortion care must be seen as part of the safe motherhood with plenty of upstream multisectoral responses. And my last slide really talks about the power of partnership, because when you talk about the deaths from complications of unsafe abortion, it's not a health system issue only. The health system can play a part on providing post-abortion care, or providing also abortion care as well, where the law allows, as provided by the laws of the land. But it's a health and justice and education system. We have to work, first of all, I know preaching to the choir, but we have to deal with the stigma that we have against abortion and against post-abortion rights, because our boys and girls, our men and women love sex. I love sex. You love sex. We are going to continue having sex. And as we continue having sex, it's going to be continued unintended pregnancies if we don't do upstream work to really reduce that as well. But also we have to deal with gender-based violence and defilement that really expose some of our girls. Law enforcement and community, I think for me ensuring timely survivor care is really important, but also the civil society and professional bodies coming in to do advocacy and learning to support the efforts of the Ministry of Health. So with those remarks, I really want to stop there, and I'm really looking forward to engaging with you in terms of that when we meet here again next year, we can actually probably see that we've eliminated completely upstream causes that make PAC necessary, but also that women are able to enjoy their reproductive justice in a society that enables them to do that. I thank you.
I think Dr. Kitui deserves a stronger, a bolder hand clap. And with that, Dr. Kitui, we're appreciating you for that powerful keynote address. In your presentation, you end by reminding us the theme of this conference, as we see on the screen, is strengthening multisectoral collaboration and mutual accountability for safe motherhood. You've helped us understand why PAC is necessary. When us understand why PAC matters. You've gone ahead to help us understand reproductive injustice and how it's going to be the iniquities that we're seeing in the country. But the bold statement that is telling us that we, the women, bear the brunt of that injustice. And it's delightful to see that both men and women are coming together in their different capacities to discuss the matter. So with that framing, allow me to get into the panel discussion. And our first speaker is Judith Isuka, who I already introduced. Judith is going to help us, is going to discuss issues around facility level PAC provision and the realities as a provider that they face, the barriers, the challenges, and the opportunities that we see as we deliver PAC services to both the young and the older women above 24 years of age, but live within the reproductive age group. So Judith, I'm going to ask you to step up and speak about the practical barriers to PAC provision in the rural facility setting, and what does a supportive environment for PAC providers look like? Over to you, Judith.
Thank you, Thank you, Dr. Lillian. I'm Judith Isuka. I'm a midwife. I work in Mukuju Health Center 4. The practical barriers we face as providers. Being a provider, we have had so many barriers while carrying out the PAC services. And one of them is the inadequate supplies and equipment, stock out of essential PAC commodities, such as manual vacuum aspirations, kit, infection prevention supplies. We have analgesics, and then also antibiotics. Those are the common drugs we mostly use, because as providers, we always handle the last minute cases, that is hemorrhage, infection, and then sepsis. So how do we go about with that? The solution would be to ensure a consistent supply chain management with the dedicated PAC commodities, whereby we have to increase on the budgets and the functional logistics, and which can coordinate, and this one could be coordinated between the districts and the facilities. Then also we have limited trained personnel, often only one or two midwives are able to give this service. And you find some of these midwives, they have to go off. And once somebody goes off, it means there's no continuity of service or someone is transferred. So you find the services are disrupted, and then also the solution would be to expand PAC training to more midwives and nurses to build a critical mass such that we have skilled midwives and providers at all lower level facilities. Another challenge we face as midwives, we always have stigma and judgmental attitudes. Some health workers and community members, they still attach stigma to women seeking PAC services, which at times discourages them from seeking timely care. So the best solution would be to do a VCAT, the value clarification and attitude transformation sessions for both the nurses and midwives, and also to make sure that people get this information. We clarify on the providers' attitudes, health workers' attitudes, and the community. And then we also have weak referral systems where you find at times these complicated cases can be delayed due to lack of transport, or you find that there's poor communication between facilities. So we need to strengthen that. We need to strengthen that gap between the providers and the facilities where we refer to. So the best solution would be to strengthen referral linkages through reliable transport mechanisms, clear referral protocols, and then also mobile communication between facilities. Inadequate privacy and confidentiality. You find most times we don't have spaces. We lack spaces in our facilities. You find that these mothers come, they want the service, but you find it is the same space, they are doing antenatal deliveries, so they have fear in seeking those services. So we empower our IPs and MOH to make sure we have enough spaces for PAC services in our facilities. You also find the rooms are not conducive enough. They are depleted, they need to be renovated, and when someone comes and sees that kind of environment, they are not even ready to open up to us. So we need to do a lot and prioritize, and also make sure within our maternity units, we ensure that we have respectful care for these mothers. So what is the supportive environment in PAC? How is this supposed to look like? For me as a midwife, I expect the environment whereby I'm valid, I'm protected, I'm equipped, and I'm motivated. So with that said, we expect availability of essential drugs. Providers must have continuous access to safe equipment, infection prevention materials and supplies, and then functional infrastructure. And then also we expect supportive supervision and mentorship from our district mentors. And then the peer learning and feedback from the people who come to give us this support, so that we are able to build our confidence and skills. We also expect emotional and psychosocial support. At times this work is so demanding, and we expect peer support groups and stress management opportunities like these ones. When you come here after that stressful work, you feel you are really rejuvenated. I expect midwives, by the time they go back from here, they are going to do better. Then also we also expect clear policies and legal protection. I'm happy I'm able to see the guidelines in our tables. So I expect that environment where I'm protected, no blame. At times you find there are risks while they are providing PAC. So with these approved guidelines, I feel the health system should be able to clarify policies and define their scope of practice, our scope of practice, and then legalize our backing. Then also recognition and motivation, acknowledging PAC providers, acknowledge their contributions through awards, career progression, inclusion in districts, and strengthen their morale. So these are some of the things which can motivate us. If in a district you can sponsor some of your midwives, it should not be necessarily the IPs. The DHOs should take this and make sure they recognize and motivate their midwives by sending them to attend this kind of conferences because they have a lot of learning. Then also expect enabling leadership, whereby facility and district leaders should advocate for PAC, allocate resources and ensure integration with the family planning and other reproductive health services. So with this said, in summary, I would say improving PAC requires investment not only in supplies and skills, but also in a supportive system that protects and empowers midwives. When midwives are enabled, women receive safer, more dignified and timely care across. So, thank you for listening.
Thank you very much, Sister Judith. I like the way she ends. So, thank you. In a nutshell, have you heard what I've said? For me to serve you better, please hear me, so that I will ensure that no young girl or woman dies because I've not been able to deliver the PAC service that they require, because I am not protected from the system that finds me guilty for delivering post-abortion care, just because there is the word abortion in the service that I offer. So this really leads us into the next conversation, that is discussion going to be led by Dr. Bagala, who is required to help Sister Judith navigate this complicated space of a health system and a strengthened, I'm not able to deliver, but also a social system that, if not protected, there is no justice for me. So I will not deliver the service. So Dr. Bagala, in your capacity, we are asking that you discuss with us the measures needed to institutionalize PAC services across Uganda's health system, in line with the guidelines that you led in the development. We are also asking that you guide us on how Uganda can strengthen the commodity security, supervision, and referral that Sister Judith spoke of. We are also asking to hear from you what lessons can be drawn on policy alignment and strongly on accountability. Over to you, Dr. JP.
Yes, thanks very much indeed, our moderator. First, to really thank every person in this room, because I think when we started the efforts around the maternal prenatal death surveillance and response, as the Commissioner highlighted in his presentation on Wednesday, and the local maternity and neonatal systems, which I provide a strategic oversight for at the Ministry of Health, we've seen significant change. But this has taken a team at national level, a team at the regions, a team at the district, and a team at the facility. And for us to be able to cascade and institutionalize PAC, it's going to take that same approach and pathway. When we realized that PAC was known as an area that was being given due attention, as the ministry, we led the establishment of the PAC Steering Committee. And we were privileged that that space had quite a number of players. But what was lacking was the central coordination. And that's what we had to provide, the central leadership. We had, as the ministry, we had to provide that piece. as soon as we instituted that piece, we agreed as a steering committee that we needed to be very intentional. And in being intentional, it required us first to look at the building blocks of the healthcare system, from the guidelines that would enable us to have a well-informed, competent workforce, to look at the commodity needs and essential supplies, which the previous speaker talked about, looking at the financing to ensure that we are pooling resources. The reality of the matter remains that we are short when it comes to resources. We don't have significant resources there available. So harnessing every single coin that we have from the various players was very, very critical. Ensuring that data is at the center of every conversation that we have as a steering committee was very critical. But also we realized that there was a bit of silo operation or segmentation in the way business was being conducted. So we really had to ensure that we are getting everyone on the same table to have a common conversation. And for me, I really want to appreciate every single partner who is part of the PAC steering committee for really layering efforts behind the vision of the PAC steering committee. And what the PAC steering committee did, as in addition to mapping the various players, was to ensure that we have that guideline. And I'm very happy that in this 5th National Safe Motherhood Conference, we've had it launched. Now, it's not to be shelved, but the content of that guideline is to be put to use. And every healthcare worker who turned up here today, let's go with that message that we have to turn that guideline into actual practice. Now, the other piece that we had to do, we realized that, okay, fine. If a doctor or a midwife graduates after school, they never get an opportunity to have their skills refreshed. But also, we had a little bit of segmentation of the various manuals that speak to PAC skills. And so we agreed as a team that let's pull all this together and have a harmonized PAC manual, which we did. And very soon that will be out. So that is contributing to the institutionalization of PAC service delivery. But it's also very important to note that we provide PAC across our different levels of care, away from national referral maternity centers to the lowest level, and that is the center 3s. And I really want to appreciate partners because I've been privileged to visit some areas that IPAS is supporting, and I was very, very amazed. I found midwives in Tororo providing pudendo nerve blocks. Very amazing and safely. And what occurred to me was a question of how can I get another midwife in Kampala Metropolitan competent enough to provide that level of pain relief? Because we've seen some clinicians providing PAC services under uncomfortable circumstances. So that speaks now to the skilling which we will have to further undertake. So through the PAC steering committee, I know the time is very limited. Through the PAC steering committee, we are very, very intentional to ensure that we leave no healthcare worker behind. And we are very, very intentional to ensure that every facility that provides PAC or maternity services is reached in terms of receiving the guidelines that we've launched in this conference and ensuring that the skills of healthcare workers that see these women are refreshed on a continuous basis. Now, the issue of commodity still remains quite critical, and I think the midwives talked about that. Now, it's our responsibility as the ministry to ensure that the commodities are available. But also what we are saying to the managers in facilities, that with the small envelope that we have, can we prioritize and ensure that we have the essential critical commodities that will save that bleeding woman who has lost a pregnancy when she reports to a facility? Because we've visited some facilities and they have stocked a good number of vaccines and rabies vaccines, but they don't have IV fluids. And we've always wondered, how are we prioritizing the way we are procuring commodities? So our gospel on preaching how to prioritize to essential critical commodities remains very, very critical. But also as government, we've increased on our resource envelope for commodities. And I think the Commissioner talked to that earlier in his remarks on Wednesday. We've increased across all levels of care.
But the intention of that increase was to ensure that we are increasing on the amount that facilities can procure as far as the essential emergence critical commodities are concerned. Now, once we have these commodities in the facilities, the accountability of their utilization becomes also critical. Now, the utilization of the commodities to ensure that they are not getting legs out of the facilities into the private centers remains very critical. And that speaks to the leadership that we are providing in our stores, the commodity stores to start with, the store managers that are managing these stores, the facility managers. We've undertaken supervisions and we found that the store managers abandoned the shop and they left their duties to just untrained nurses. So the management of commodities remains very, very critical. And that speaks through the entire cascade of leadership. Now, the regional mechanism is very important to foster all that. The local maternity and neonatal systems are very, very key. And we are very intentional at the Ministry of Health to ensure that every LMNS is supporting efforts to do with reproductive, maternal, newborn, child, and adolescent health. Because that's our regional RCH framework at the Ministry of Health, and we want to ensure that the regional referral hospitals are also supporting the lower level facilities. We started what we call the integrated technical support supervisions. The issue of supervision remains a critical challenge. As the ministry, we've revised our approach and modus operandi to make it very intentional, and we want to encourage our district colleagues to be very intentional when it comes to an issue of supervision. And when we say supervision, it should be intentional. It's not just touring facilities, but it's appreciating what these facilities and the healthcare workers in those facilities are doing. While we are struggling with issues of absenteeism, both organized and non-organized absenteeism, is because we still have gaps in supervision. If the facility managers don't do their job, and if the districts don't help us to be strong on the issue of supervision, then we shall not perform as a country. So it really starts at that lower level, and then it cascades up. The results start from even the head of maternity, that in charge, you as an in charge, a midwife in charge of labor suit. Are you able to account for every single officer within your unit? We've seen rotas, duty rotas that have been manipulated to cater for organized absenteeism in facilities. Those are things that we have to individually reflect on, because at the end of the day, we're not serving the people that we are meant to serve. The issue of mentorship, I've talked about that. That must continue. And my colleague here talked about how we have to strengthen our referral pathways. That is very, very critical. The issue of referral pathways, yes, we've tried as the ministry to ensure that we have the vehicles in place. But it's not just about the vehicles. And moderator, please, you lend me the minutes left because I can speak to you tomorrow, but you just tell me that I have 2 minutes and then I can stop. So the issue of just having the ambulance is not enough. If I have a mother and I've received that mother in a level 2, but this mother, I appreciate with my conscience and skill and knowledge that I cannot manage that mother, how do I facilitate the movement of this mother to a level where she should be managed safely? But also to ensure that when she reaches where she's supposed to go, they are ready to receive her and respond to her timely. In most cases, we contribute to the second and the third delay, obstetric delay. So it's upon us, and the reason we come here is to reflect on how do we ensure that we are doing more of what we are supposed to do to save and ensure that the lives of women are protected. I talked about the issue of procurement, that we have to be very intentional and ensure that we are prioritizing. And I really want to conclude with these 2 issues. Every single person in this room is a leader. Every single person. For as long as you're a healthcare worker, you're interacting with colleagues on that unit where you are, and that takes particular leadership skills on how you communicate, on how you interact, on how you handle complicated patients. So you are a leader. Can we exemplify those skills of being leaders? Every single health facility manager, every head of the district, the DHOs, the ADHOs, every single chief administrative officer, and for us at the Ministry of Health, we have been given the opportunity to serve our country. Can we do it with the utmost effort that we can? Because there is another person out there that doesn't have the opportunity that we have. Leadership, governance, and accountability. And accountability should be at the center of the safe motherhood movement, for which we are having the conversation today, but also should be at the center of every single effort that is going to ensure us that every single mother in this country receives quality, safe PAC services when they need them. Thank you.
Thank you very much, Dr. JP Bagada. I think Dr. JP is in a very hot seat because we all turn and look at him with the expectation that the ministry must take care of us. So as he spoke to critical issues, and he reminded us of the fact that for us to manage PAC and the unsafe abortions, we must, from the health perspective, frame them within the health system perspective. So he talked about the WHO building blocks of health system strengthening. But out of that, he spoke of things that we must be aware of and are held responsible for as health workers, but also collaborative partners in the delivery of the PAC services. So allow me appreciate the ministry for their boldness in coming out and guiding us on developing the guidelines. And we must recognize the effort that they put into this whole system. Teenage pregnancies is difficult to talk about, but they've again come out and said, because the young population is dying off, let's work together with the PAC committee and develop the guidelines. Let's develop the LNMS system to guide the delivery of services, inclusive of PAC services. So I think the ministry deserves more recognition for the great work that they do. Because many times we come out and say we facilitate the ministry to deliver the work that they're supposed to do. So we take a back seat as partners and leave them in the hot seat. So we thank you, Minister of Health, under leadership of Dr. Mugahi, for the boldness that you are putting forward to manage the issue of unsafe abortion, but also provision of PAC services. So a round of applause to the ministry and to Dr. Jeffy for speaking to this matter. But allow me to emphasize one more thing about supportive supervision. The other day or yesterday, Dr. Richard spoke about the empty ANCs that we offer. It is very plausible that when we go out to deliver, to provide supportive supervision to Judith as they offer services, we also provide empty supportive supervision. We go in, we make a round in the city, we check, do you have this, do you have the other? Then we go away. But we never sit down to provide that guidance for them to feel valued and supported. So it remains a call to us all that when we go in and say we are facilitating the means to deliver services, what exactly are we doing as we are holding them accountable for the delivery of services? So thank you very much, Dr. JP, for that great deliberation. And this gets us into the learnings that we must learn from our neighbor, Kenya. So I'll ask Dr. Lois Nyanjao to come up and speak to us about what strategies that Kenya has used to reduce unsafe abortion-related mortality in their country, and how Uganda can translate policy frameworks into routine PAC delivery. Over to Dr. Lois.
Thank you so much, colleagues, and I really want to thank the government of Uganda, Ministry of Health, for inviting we from Kenya, Ministry of Health, to come and share our reflections on our landscape in matters PAC, and congratulations on releasing the PAC guidelines. It's a really strong step towards doing justice. I want to appreciate Dr. Kitui's keynote address, where he took us through a root cause analysis, and he asked the 5 whys of why women and or girls are dying from complications of abortion. And he walked us through the journey of getting to the upstream causes of the challenge that we're facing today. And that frames very well this discussion we're having today on reproductive justice. So thank you very much, Dr. Kitui. To respond to the area I am to reflect on and to share what Kenya has been able to put in place in responding to the challenge of mortalities relating to post-abortion, I would like to invite us to think it through the funnel approach, moving from outward, coming in, and this leads us straight to a right-based care notion. As a region, when I say region, I mean the East Africa region, we are party to international treaties and conventions. For instance, we are all party to the Sustainable Development Goals, where we have a responsibility to deliver on SDG 3. We are party to the African Union Charter, the East African Community Treaty, and others. And all these treaties and conventions require that we provide the high standard of living and well-being for our populations, and we also harmonize our health policies. So we are invited to learn from each other and harmonize the health policies so that we as a region, we are brothers and sisters really, divided by artificial borders, but we bring or carry the well-being of our populations first. So in line with the responsibilities we have to the global community and to ourselves as a region, Kenya took this and inculcated in the Constitution of Kenya 2010, providing that all Kenyans have the right to the highest attainable standard of health, and tied to this is the right to emergency care. Picking from that, our legislation, which is the Health Act of 2017, provides that, or rather defines health as the state of physical, mental, and social well-being, and therefore ascertains that all Kenyans must access care as enshrined in the Constitution. Based on this, we then developed our health policy and our reproductive health policy, 2022 to 2032, which assures or provides that Kenyans will get unhindered access to maternal and newborn health care, including services that lead to the termination of pregnancy where it is medically indicated. Learning from this or picking up from this, we then developed our post-abortion care guidelines. And these guidelines essentially assure Kenyans of services for post-abortion care, which in our context begin from the point where a woman or a girl presents with bleeding. So we will frame our discussions from this point in the context of Kenya. The PAC guidelines in Kenya are anchored on 5 elements. One, the first and foremost being counseling and awareness raising for our clients, and then treating the complications of incomplete abortion, managing any comorbidities or pre-existing conditions, providing family planning choices and services, and then building up partnership between the community and the healthcare providers. And when I took a glance through the PAC guidelines that are just released in Uganda, I find that all these 5 elements are instituted in the guideline, and in addition to which I am learning from, and I'm really proud of Uganda for this, including the standards for post-abortion care within the same document. And I think this is an area we should commend Ministry of Health Uganda for. Thank you very much. So, in my view, and from the Kenya experience, the learning that I find is worth sharing is that we have really transcended the notion of access to healthcare and access to emergency care throughout the policy framework, starting from the Constitution of Kenya, through the Health Act, through the health policy, through the reproductive health policy, and eventually to the PAC guidelines, so that we enshrine and keep sharing the same message that our women and our girls deserve to receive unhindered access to care, and for that matter, emergency care should be universal. In the translation of policy to practice, I want to align with the comments made by Dr. Bagala that this practice should transcend the 6 building blocks of a health system. The governance structures and the leadership initiatives are paramount. And I'm really encouraged, and I learned from Uganda on there being an agency that drives the leadership and governance in matters PAC, where we have in Uganda, you have the PAC steering committee, and I think that's an area for learning from the region. In terms of health financing, we have to accept and be intentional in generating and using the evidence on the return on investment in implementing or responding to abortion or post-abortion related issues. Without evidence, it becomes hearsay or ad hoc information, and we have to learn to use and generate that return on investment evidence for all of us. On matters of human resources for health, in Kenya, we intentionally have standardized messaging at the pre-service and the in-service level so that we harmonize the knowledge that is utilized by our health workforce in responding to unwanted pregnancies and also the complications that come to incomplete abortion. One area that I find stands out very strongly, and I believe it needs to transcend beyond the health workforce, is the use of VCAT. VCAT stands for Values Clarification and Transformation, where we as stakeholders in this sector, we analyze our own individual values, biases and perceptions, and reflect on what is really important for our clients. So whenever we are building up that capacity or training on post-abortion care services, we require that each individual is taken through VCAT. In the area of health products and technologies, and I'm really appreciate the discussion that has been done by Dr. Bagala and Judith, I acknowledge that we seem to have similar challenges in Kenya and perhaps maybe in other jurisdictions. Supply chain security is an area that is growing, and I hope that we can also pick lessons from Uganda and build on that. Other than including post-abortion care commodities in the essential list, making sure that they reach to the lowest level facility, and even in the case of jurisdictions that allow to the community level, it's an area that we definitely should build up. In the area of service delivery, in Kenya, we have integrated PAC services in the normative service areas for maternal newborn health and the outpatient areas. In the community level, it's an area we are building up. Our community practitioners, who are we call them now community health promoters, are now a paid cadre, and that has really helped us standardize and increase the reach and scope of community services, which is more so education and referral for services. Health information systems cannot be understated. Their role in enabling decision-making, in generating evidence, and supporting continuous improvement is something that investment in should begin at scale and be maintained in there for prosperity across board. The partnerships that enable this robust provision of services sometimes can be touchy, I agree, in terms of PAC, but they must be fostered and they must be cultivated. And I will repeat, in my view, if we all undertake values, clarification, and transformation, I believe the partnerships across board, whether it is in public or state and non-state, or among CSOs or among other constituencies of community engagement, I believe that will really build up healthier conversations. Thank you very much, and I look forward to engaging with you all.
You know that saying in the Bible that says iron sharpens iron? Or did I choose it from the wrong book? But as Dr. Lois spoke and Dr. Bagala kept shaking his head, I understood that he understood what he needs to go forward with. So thank you very much, Dr. Lois, for ably speaking the issues that you're facing, we are facing, and what we can pick up. At the start of your conversation, you did say that your guidelines that you have are very integrated. So even when we have launched ours, we are required to go back and do a quick review. To what extent are they integrated to deliver appropriate services to the person who needs them the most? So Dr. Bagala, I trust you have picked everything you need and we have what to move forward with. And all members of the PAC steering committee and everybody present, because we, even though the guidelines have been launched, we need to improve them for the betterment of the well-being of the people of Uganda. So thank you very much, Dr. Lois. You did mention about evidence. You did mention about the BCAT, how far we can go with that. You did mention about governance and also digital or AI-related issues. So this leads us into the next conversation by Dr. Polify, where we are, as a researcher and an academic person of academic background, we would like to learn from Rwanda how you have navigated the legal ambiguity and provider hesitance with evidence. We also want to learn more about the innovative models that Uganda can adopt from Rwanda's PAC system. I'm trusting you do this in just 7 minutes. Thank you.
Thank you so much. The ambiguity around post-abortion care is a common problem everywhere in the world, and interestingly, even in the developed world, where they have all the resources to look into their problems, it still persists. But nobody is going to respond to our issues here if we don't develop our own eyes, our own lens to look into our own problem. Rwanda has taken that as a personal problem, and we navigated it with stringent mechanisms. So some of the key mechanisms that I can share, there has been policy clarity. So the government of Rwanda, through the Ministry of Health, issued clinical guidelines and ensured they are very well implemented with standard operative procedures that puts post-abortion care as part of the routine care. This did not only shift the issue of abortion from a morality standard, but it also made it as a duty to treat. So we are trained at school, but when it comes to providing this, sometimes we hesitate. So this made sure that it's translated. There has been also strategies for task sharing and shifting. So most doctors, including myself, but I'm a gynecologist, but I remember very well that I was trained how to do a digital vaginal exam or labor monitoring by a midwife. So how to ensure that the uterus is well, in fact, there is no retained product of conception, that retained placenta that may lead to postpartum hemorrhage. So all these, the essential techniques were by a midwife. But at some point, we had a policy that allowed only doctors to do this post-abortion care, offering these services. And somewhere in the middle realized, but they are trained by midwives, there's essential skills, so why don't we allow the midwives? So the government of Rwanda, the Ministry of Health, ensured that the tasks for women suffering from abortion complications, abortion process, who are coming for bleeding from abortion, they can be managed by the midwives. And we trusted the midwives because we trusted the education that they are given at school. And also VCAT training has been emphasized for both in service and the pre-service training, which reduced stigma and emphasized the professional duties. So also accountability. I love that from the very beginning of this conference, all the keynote speakers and our chief guests, they all emphasized on accountability. So Rwanda took accountability and also quality improvement activities on its hand, doing facility audits, and look into the near-miss events, not only maternal deaths, but also near misses. So did we really need to have to give transfusion to somebody? Why couldn't we have done something different to prevent going this far? And also we looked into post-abortion care indicators through our HMIS portal, and we discussed the DAY3 data and what it means to our own population. We emphasized on patient-centered care, so special care for adolescents and people with other people with special needs, ensuring every health facility has a dedicated care for the marginalized communities. So nothing is going to work if we don't put the key, the service users into consideration. So with our 4x4 strategy, healthcare workforce, in the next 4 years, Rwanda has made sure that women are part of this movement. We increased the number of women attending medical school and residency program and other advanced training, fellowship, and so on. They do understand better the problem of women, and they teach other care providers better than other educators that based on research only. So, and also partnership with other organizations, and we looked into the regional capacity. So I think Uganda can also learn more from what is existing. So when you look at the policy, the post-abortion care policy, and the research policy in Uganda, it has the key components that can really translate into healthier practices and prevent maternal mortality and morbidities, and we all have a safe motherhood. So there is this one model they call the Kingdom model of agenda setting. Post-abortion care can need to be on the national agenda. So it's not going to work if, as care providers, we don't generate sufficient data, we don't take the genuine data, and we speak to the policy and see, are we conflicting with the policy? Then the policy knows we are conflicting with this, and then it also informs the political will to look into it. So the clinical guidelines, I love that they recently, during our first day, they launched the guidelines. And one thing that we need to do is trust these guidelines. They were developed from our own data, our own information. Even when you don't necessarily agree with them, trust that they are meant for the best health of a Ugandan. So, and also capacity building. So generate e-modules that can teach people on post-abortion care, provide mentorship and provision of doing maternal mortality and morbidities that are related to post-abortion care. So I've learned that the DHIS is well used in Uganda, and it can be also an entry point to look into what we are doing, what are the main causes of maternal mortality and morbidities when it comes to post-abortion care. So, and emphasize on community referrals and continuity of care. And when there is no national capacity to advance or increase access to post-abortion care, use the regional capacity. There is some capacity in Kenya, there is some capacity in Tanzania, there is some capacity in Rwanda, Burundi, Ethiopia. Let's take this and use them. And in the end, finally, to prevent the need for abortion, let's accelerate the uptake of contraception. Thank you.
Thank you very much, Dr. Profile. He speaks French as his first language. So we are delighted that he could aptly articulate critical issues. And he ended by saying, we are the East African community in a few words. So we have the opportunity to learn from our neighbors. I'll emphasize that iron sharpens iron. And when he reminds us that we as Ugandans know our problems, so we must create solutions or design solutions that suit our problems, then he speaks to what Dr. Kabanda spoke yesterday, that we must co-create our solutions because they could be different in different contexts and regions. Dr. JP spoke of the LNMS system. You know that we have regional LMNS systems. The issues in Kampala are so different from the Borneo region. They're so different from the Eastern region. So we are reminded that we know our problem, so we must deal with our problem within our context. And Rwanda is known for taking what we have designed and implemented. But he's reminding us that even them, even when they are adopting what we have, they first understand the issue and utilize our frameworks to make their life easy. But data remains the essential or key ingredient as you're designing and developing your programs. So thank you very much, Dr. Polifile, for giving us a better understanding of how you navigated the legal ambiguity and the provider hesitancy. You spoke about the task shifting. You're reminding us of the BCAT, or you're reminding us of the accountability framework that you're utilizing and the special models. But you're also telling us that we have special groups that seek services. You talk about people with special needs, and I hope that those will have data that helps us address that specific needs that come to PAC service delivery. We have come up, a few questions have come up that we should take a moment to address. Many are very specific to the different countries, to Rwanda and to Dr. Lois as an example. But you can take a moment to view them. And in 1 or 2 minutes, then we'll be able to address them. The person managing the screen, do you mind going back to the first question, please? We need a deliberate move to enroll the private sector providers while implementing PAC guidelines. Dr. Jeffy. The second one, and the PAC committee. Number 2, how can you integrate contraception in the school health care package in order to reduce the issue of unsafe abortion? I will read the question again. I'll say the question again. How can we integrate contraception in the school health care package in order to reduce issues of unsafe abortion? I'm reading it again intentionally because we've had comments about the sexuality education package. And unless we look at it critically and understand the needs of our country, then we might not be able to address that question. But we have an opportunity to look at it deeply. Then how can we handle the issue of schools which expel students after being identified pregnant? This has led to many girls doing criminal abortion. What is being done to handle the issue of private clinics doing illegal or induced abortion and referring severe cases of failed or incomplete abortion? Dr. Lois, have you seen, thanks, how has Kenya handled challenges of BTS, traditional birth attendants, when it comes to safe abortion care? Okay, safe abortion care, what drives implementation of strategies to curb TB activity? In our communities, many women still believe that after abortion, they are to get pregnant, so it is difficult to convince them to use family planning. I'm going to ask our panelists, Dr. Lois, Dr. Judith, and Dr. JP, in 1 minute, to each address the questions that are coming to you. Dr. JP, the issue of school and sexual and sexuality education, definitely coming to you as government, because you know the frameworks and the guardrails around it. Then Sister Judith, you speak about what you're seeing in the community and the TPAs if you can. But this also goes to Dr. JP, briefly. After the response to those questions, then we have a special guest online who would like to make comments to the meeting. So quickly, please.
Yeah, thanks very much indeed, our moderator. Yes, it's true that we have work to do when it comes to the schools, but when it comes to adolescents and young people, we are looking at the school and out of school, because also the out of school are quite significant. But very importantly, our school adolescent and school health guideline is really informing our interventions, and we've established district committees to support both the schools and the out-of-school adolescents. We've instituted accountability platforms which happen every Friday, targeting the adolescents and young people. And we've taken a multisectoral approach and it speaks to our theme today, the multisectoral approach in addressing the issues affecting the adolescents, but also improving safe motherhood. And that brings on board the Ministry of Education, the Ministry of Gender, Social and the Ministry of Gender, Labor and Social Development, and the Ministry of Health. But also we've onboarded heads of schools, we've onboarded the cultural and religious leaders, because we believe that the conversation around how we can improve and tackle the challenges of the young people in schools, all out of school, requires that multisectoral approach. And on the issue of the TBAs, we remain very intentional. We've issued a guideline as the ministry on how they should be approached, and we continue to track that through our respective districts to ensure that we avert mortalities that are happening within the TBA practices or clinics. Thank you.
Thank you very much, Dr. Bagala. Dr. Lois?
Yes, thank you very much for that question, very important. In the Kenya experience, and I believe in this region, traditional birth attendants are a very critical component of our society. And in Kenya, I would say probably 10 years ago, we took the approach of more of a radical approach to ban activities by the TBAs, but this did not succeed very well because they are really a valuable resource within the society as perceived by our population. And so we changed approach, and we now have taken them in as part of the workforce within the community. We have transformed these practitioners to what we are calling community health promoters. We train them on delivering awareness, education, and linkage within the community, and we enroll them as community health promoters. And this has really improved our scope and our coverage in matters, education, and linkage from the community. So Essentially, we applied VCAT, and I will keep repeating, VCAT is a game changer. You may not call it VCAT when engaging with the community members, but the principles remain the same. Clarify the values and transform the attitudes so that you achieve the end goal that you're looking for. Thank you.
Thank you very much, Dr. Lois. You're becoming a doctor, Judith. I declare that. So I keep referring to her as Dr. Judith, but Sister Judith, in 1 minute, please. The question is about the community. It has kept running. How we are involving the community in the management of post-abortion care. It was among the first questions.
What we have done as the Tororo, IPAS has been able to fund some community organizations who are giving information. They have been able to train VHTs, they have been able to train peer champions. These are people who are already on the ground and they're giving in information, they're meeting the religious leaders, the cultural leaders, and then ourselves also when we go for outreaches, community engagements, we give this information and people are able to get it. That is how we have managed.
Okay, thank you very much, Sister Judith. More questions are coming through. Many are directed to Dr. Lois, the learnings we're getting from Kenya. Many are going to Dr. Bagala as the Minister of Health lead person, and others are going to I think the learnings we're having from Rwanda. And I'm going to propose that as many of them are pointing to the quality of care, many of them are pointing to the frameworks, the health system strengthening, WHO building frameworks. So we are being guided on how, or we are being questioned on how we can best deliver quality PAC services and in which framework. We are also being asked, how do we manage post-abortions within the education system because they exist. We are being questioned on how we've institutionalized the existing frameworks in the country. For example, in the community we have TBS, how do we best work with them? Because even when we try to curtail them, people will still seek services from them. I think it's a question for us to go back with and be able to address. And hopefully when we return in the next 1 year, we'll be able to speak to them or even speak through them as the year goes on. There's a question about the private sector. I need to confirm that the private sector is greatly involved in this delivery mechanism about PAC services. But a question I think that remains to us is how well are we controlling the quality of care in the private sector? Is something for us to deeply deliberate upon, and it has been talked of over and over again. We have an important speaker online who should be speaking to us, addressing us shortly. But if it's agreeable to Dr. Mugahi, can I close this session and then we'll ask them to speak to us. So we'll do this very quickly. We were set to complete this conversation in about 15 minutes. I want to confirm to the audience that we have taken the questions, we have tried to package them, and I hope that as we reflect on this session and in the closing remarks, the questions will be highlighted about PAC because it's a delicate conversation, and we'll have commitments on how to address them within the next 1 year. And when we are returning a year later, we are speaking with tangible results on how we've managed that process. But before we close this session, and before we get the last thinking from every panelist, allow me to boldly pose this question to us and reflect on PAC and unsafe abortion in the country. I recognize the challenges of speaking about it, yet it is the open secret that we all don't talk about. So We have heard from our panelists that post-abortion care is multifaceted. It's an issue that the medical, legal, social sectors must deal with, but it remains a very personal issue. We've explored issues about service delivery, we've heard about the health system, we've heard about the legal issues, and what Rwanda and Kenya have done and what we must learn. Now, I want each one of us to pause and reflect deeply because it's a personal issue. And if we take a step back, be able to speak about it because we're running out of time. I want us to think deeply, and we can give our responses in Slido and say and address the question that how can we foster open dialogue and greater public understanding of PAC as a critical element of safe motherhood? I ask again, how can we foster open dialogue and greater public understanding of PAC as a critical element of safe motherhood? If you can please type into Slido. We'll be able to see that at the end or at the break time. How can we foster open dialogue and greater public understanding of PAC and a critical element of safe motherhood? As we reflect, Dr. Mugaki is coming up to invite Dr. Atwine to address the session.
Thank you so much, Dr. Lillian. And without any more comments, it's a very sensitive and nice discussion, and the conversation will continue. I want to invite our PS, someone who is very passionate about maternal and child health. PS, we are in DAY3. I know you are rushing to the airport, but please address us as you move to the airport, and we are happy to hear from you. IT team, please, I don't know where you are, if you are able to do visual, but go ahead, Dr. Atwine. Thank you.
But I want to thank you so much for organizing and coming to attend this Safe Motherhood. Am I clear? The network. I'm in transit. I'm just going to the airport. I don't know whether you are able to hear me properly. Are you able to? Am I clear?
Yes, we can hear
you. First of all, I apologize for missing this very, very important meeting that I was looking forward to, but I had to leave to represent my minister, who is right now busy in political activities. And I really felt so bad that I missed this Safe Motherhood, because it is always very, very close to my heart. I want to take this opportunity to thank the organizers of this meeting, the sponsors. Without you, would not be able to convene this meeting. And I am glad when I joined, were really talking about the lessons learned from different countries, but also emphasizing the multisectoral approach as the theme of this meeting. The meeting I'm attending right now here is attended by global leaders. And the shift now is going back to multisectoral and really talking in real sense of multisectoral approach. Because sometimes we talk about multisectoral approach and collaborations, but it remains superficially implemented. The global community is now realizing that the way to go to manage all these challenges that we are having lies in integration and multisectoral approach. And I'm glad, I believe all of you in the room, I don't know which people attended this time, but I really want, hopefully, that in the subsequent meetings, we want to see education present, gender present, so that it is really a collective effort. It is very, very clear that Ministry of Health and partners cannot do this. We can only do this and do it better if we work together and each one playing their roles. One area that is still not very well implemented, and I think when I joined, the discussion was ongoing on school health, on girls in schools, and we need really to focus on adolescents. The issue of post-abortion care, I found under discussion, it is something that we cannot discuss in detail in the meeting like that. It needs a critical thinking, a deep dive in the factors that are causing our girls to go for abortions. And we will not change this because these are our values. We will not continue to embrace abortion as a country, but we must look at the factors that are leading to these girls getting pregnant at young and tender age, and they opt for abortions. We are also cognizant of the fact that many of our girls still are getting pregnant and drop out of school. And that affects their future, it affects their livelihood, and sometimes it leads them to having complications at birth. The efforts that we are making as a country are yielding results because we are seeing, I think that even teenage pregnancy has slightly reduced, but it still remains a big burden. I want to congratulate the teams that have been working very closely with the school health and also the communities to make sure that the girls, even those that they drop out of school, are supported. I want to thank partners that have come through to support these young girls, especially in rural areas, that the ones that could not go back to school. But the burden remains a very big problem for our country. I pray that in the next Safe Motherhood, it will give us opportunity to showcase the interlinked activities, the integrated activities between the line ministries of gender and education and other relevant ministries like local government and agriculture, and all those are factors that somehow are leading to these girls dropping out and getting pregnant and getting all these complications. And so we really need to continue to be intentional in looking at the factors, addressing the factors in totality, a more comprehensive approach. I do believe that the efforts that we have put in the last few years, they have brought us results, and really we celebrate these results. But at the same time, I know that the burden at hand is still big. When I joined, one of the persons was talking about the TBS. As a country, we will not adopt what other countries have adopted in accepting TBAs. What we need to do is to continuously educating our masses. I do believe in years to come, when education levels get better and we have less and less people, the less educated population, they will learn the effect, the bad effect of TBAs. And therefore, we will not be able, and we should not be very quick to take on other people's experiences. We must, as a country, stand out and educate the public. We must educate and actually focusing on the dangers of having our people kept at the TBAs for long and we lose lives. We must bring out the statistics and evidence-based discussion to the population so that they are able to learn from first-hand experience. We will not go back because the generations to come will be more cognizant and more educated. I believe they will not be able to go to the TBAs. We have brought closer the services to the people because now 91% of the population are within 5 kilometers reach of our facilities. And so the message must be very clear that you do not have to go to the TBAs. The facilities are near you and they are able to. And as we continue to improve the services at Health Center 3s and making sure that they are more functional and they are more equipped and staffed. Once we start implementing the recruitment of as according to our structure, our new structure, we will have doctors at Health Center 3s. That means in every sub-county, we will have doctors at Health Center 3s. And therefore, there is no reason whatsoever we should go backward and start talking about going back and use TBAs. And therefore, we must be firm, we must be consistent, we must be deliberate, and we must design our programs that will take our population forward in terms of knowledge, in terms of understanding of why we have to go to facilities instead of the TBAs. So I really wanted to put that one very clear because we will not go backward. We will not be able to say, let's go back and bring TBAs again and train them and blah, blah, blah. No, that one we close the chapter and we will not go backward because our population now is more educated and more, they are nearer the facilities. The task that is at hand as government, we need to make sure that we put services, proper services at Health Center 3s. And we make sure that we have equipment, we have the medicines, we have the staff, so that people have no reason to go to TBAs. We must ensure that we have quality services at facilities that attract the population to come to us for care. We must be able to speak about the ills, the evil that are associated with going to TBAs. It is a journey. It will not, definitely the mindset is still, we have to deal with the mindset of our people. We have to continue to educate them. But I do believe that continuously educating the public, we will get to a time when we will not have those TBAs and they will have no job. They'll run out of job. That is something that we are very optimistic about as a country, and I do believe that this is the time to get our shoes on and we make sure that we deal with seriously the issue of TBS, because it is something that is contributing. Like I missed your presentation. I really wanted to see whether we have some data regarding the mothers that have died at the hands of TBS, but I do believe that they are significant even now. So the work is cut out for us for the next 1 year. As we talk about multisectoral approach, we need to discuss the integration. I was very happy when I came in this meeting, and from the time I got here, they are talking about integration, and they're talking about integration in a manner that I have not heard it before, because the world has realized that that is the only way that is going to help us. So the activities concerning adolescents, the activities that we are going to implement moving forward, that are going to give us even better results, quicker results, more resounding victory against these evils we are fighting, are going to emanate from how we are going to integrate together with other line ministries and activities. And I hope that really moving forward in our safe motherhood conferences, we want to see all these ministries participate. I would be so glad to see and to hear what education is doing, what activities we are undertaking in schools by education, because we cannot implement these activities ourselves as health. We want to hear what education is doing, the practical approaches to integration as far as adolescent health is concerned. Activities on post-abortion care, activities on obstetric and community, because we have even gender. I'm glad I think PS is the one who opened the the youth conference. So we need to see now what the activities, why at the implementation level, and how is local government coordinating our activities at subnational to make sure that we are all together, we are moving together. So these are things that we want to foster, we want to continue talking about. And I really want to take this opportunity and apologize very, very much that I have missed. But I know that you've been having great time. Thank you so much. I saw the attendance. I was watching on YouTube. I think the attendance has been great. And we just convey our condolences to the family of our midwife who died in an accident while she was coming to attend the function, the Safe Motherhood Conference. So allow me, as I conclude, I want to congratulate all of you. I want to congratulate our staff, right from the VHTs, the CHUs, the midwives, the doctors, the LMNS teams that have been religiously meeting, the other leaders like COW, RDC, LC5, and other partners, especially the implementing partners and development partners that have been supporting us in this space of safe motherhood. Thank you so much. The guests that came from our neighboring countries, the guest speakers, we are very grateful. We have missed, I've missed you because I was looking forward to meeting you. But we hope that God will keep us safe and we shall meet next year. God bless you, and we wish you the very, very best of the day. Thank you so much. Bye-bye.
Before you go off, I believe you've heard the up Dr. Tuna, before you go off, I hope you have heard the applause from the audience.
Yes.
We all
Thank you.
recognize the challenges that you faced in being present with us in the last couple of days, but we are very grateful that you took a moment to speak to us and remind us of why we exist and the role that government is playing in ensuring that the population lives healthier lives and we achieve Vision 2040. Thank you very much, Dr. Twain. The comments you have made, we've taken them at heart, and the conveners of the conference will ensure that through the year and when we return at next year in 2026, we will be able to respond to those issues that have been raised. Thank you. Allow me, members or audience, to close our session, recognizing that Dr. Atwine has spoken to critical issues that came up during the conversation. Given that we should be closing by 10:30, I will, on behalf of the panel and the keynote speaker, I'll ask Dr. Kitui to give us one commitment based on the keynote address that he made and what members and the question that came up to us and the point of reflection as we frame PAC from the reproductive justice perspective. Dr. Kitui, briefly, please.
Thank you very much. Lillian and Dr. Diana online, we really appreciate those comments. I know our time is fast spent, so I'll be very brief, but I want to ride on what the PS has said. I think health services at facility level must make it easy for women to come. And so I think that's a critical, important, place for us to start. I think the other thing that I want to really take away as well is that the issue of why our women and girls are choosing to have unsafe abortions that makes them PAC necessary is a conversation that probably requires a deeper conversation. And I think that's probably an invitation for the ministry to convene stakeholders to have that conversations around, if you remember the diagram I showed, what are the upstream causes of these unsafe abortions, so then make PAC necessary, so that as a society we can address them and deal with them. And I think as we do that, I just want to pose one question that all of us have to think is, I think we've talked about lived experiences a lot this week. And I think for me, as we design health systems, as we work with ministries of education, as we work with law enforcement, for example, one question we always have to keep ourselves asking is, what do women want in 2025? What does women want when it comes to reproductive justice, when it comes to security and safety? A lot of the unintended pregnancies arise from violence, from incest, from rape, from lack of skills to negotiate safe sex and everything else. I think as a society, we can't run away from that question. And I think it's a question of reproductive justice, asking what do women want? And then organizing services, not around any ideology per se, but around what really women want in this age and time. Thank you.
Thank you very much, Dr. Kitui Musova, and thank you to the panel. Together, I want to reaffirm that today's dialogue has reaffirmed that post-abortion care is not just a clinical intervention. Government, they recognize the burden of unsafe abortions. They further recognize that it's greatest among the adolescents and young women. But she has guided us to say that we must remain firm, consistent, and deliberate to manage the issue at hand as Ugandans, even as we adopt learnings from our neighboring countries of Kenya, Rwanda, or the East African community at large. She has also emphasized the fact that the framework that have been done, or we have already implemented, we must take integration and cross the T by having a full understanding of what integration means, and not simply scratch on the surface of what integration is. She has reminded us that it is multisectoral management, that we must go beyond Ministry of Health, we must have Ministry of Gender, we must have Ministry of Education, and we must have Ministry of Local Government, because that is the spaces in which we live. So as we close this session, We are all required to carry forward the urgency and clarity that this session has ignited. Let us commit to protecting the providers, the midwives, the nurses, the doctors must be protected because they too require justice. We must protect and empower communities because we know that TBS who are still existing live within those communities. And even we must protect our minds as individuals because of what we believe and what we trust and define as urgency and power. We must also embed PAC within Uganda's safe motherhood agenda, not as an exception, but as an essential care. Allow me and join me to thank Dr. Kitui, our keynote address, our speaker, thank Sister Judith from Tororo Municipality or Hospital, thank Dr. JP Bagala, who's an organizer of this conference, but has been able to speak about government's perspective about PAC. Join me in thanking Dr. Lois, all the way from Kenya, who has spoken to us about what they're doing in management of PAC. And also Dr. Polifil, who is speaking from Rwanda's perspective in academia and the legal ambiguities. We believe that the recommendations that have been made, the insights provided, will all help us manage the unsafe abortion issue that stands before us, and we will be able to translate all this into action, accountability, and lasting change. I believe that together we can build a future where every woman and girl has access to safe, timely, respectful care, because reproductive justice is not an option, but it's fundamental. Thank you very much.
Please, let's take some photos. Please, let's take the photo. Yes, let's take the photo. Quick photo for this very powerful panel. Thank you very much indeed, colleagues. It's time for break tea. And tell me where to look. All right, so colleagues, let's go have some tea, all right? Let's go have some tea. 11:15, let's be back. 11:15, let's be